let's go ahead and get started. In this session, in this webinar, we're not talking about that. I got the wrong one up. Sorry about that. Where did we go? Where do we go? Okay, good. Well, let's start that all over again. That's so funny. Okay. Welcome to tonight's webinar. Tonight, we're going to be talking about the diabetic workup. So we've got a lot of things to actually cover here, and I think you'll get some neat clinical pearls on here. If you're part of the DAPC 2025-27 class that we're just now finished the second module on last weekend, we're really kind of pulling into that. We just did physical exam, so I wanted to give an opportunity just to go through some things in the diabetic workup, as well as I've got a case that we're going to work through. So let's get started in here. First off, a really good thing just to look at, just for a little bit of awareness. If you haven't seen these stats, they are actually fairly mind-boggling. I mean, these are big numbers. So this is according to the CDC among U.S. population overall crude estimates of 2021. So that's the latest that they have on there. So 38.4 million people of all ages, or 11.6% of the U.S. population, had diabetes. 38.1 million adults aged 18 and older, or 14.7%, and 8.7 million adults 18 years older who met the criteria. It goes through there. But the bottom line is, if you look at this one, this bottom one here, the percentages of adults with diabetes increased with age, reaching 29.2% among age 65 years and older. So my question to you is, do you take care of patients right now that are Medicare? Do you take care of patients that are 65 years old and older? If you do, 1 out of 3 of them has diabetes, according to the CDC. Now, these numbers even get more scary. This is pre-diabetics. So let's just talk about pre-diabetics. So if you look at pre-diabetics, we have 97.6 million people aged 18 years old or older have pre-diabetes. That's 38% of the U.S. population. If you're 65 and older, then you have 48.8% pre-diabetic. That's half of the people that walk into your door are actually diagnosed as pre-diabetic. Now, I'm going to show you through lab work how you can determine whether somebody's pre-diabetic, but it's functionally, but it's not showing up even in that criteria, because there's a whole bunch of people, and that percentage gets even higher when you know how to read the blood work. All right, so this is a really great slide. We talked about this in the module that we just did, but I want to reiterate it because it's just so good. So this is an article that I read. It's a journal article. It's actually published Medical Index, I believe. And they talk about the deterioration in physical exam skills. So what they're talking about is doctors, primary care physicians, losing their ability to do a basic physical exam, and then they talk about the detriments of that. Now, having said that, we say physical exam, but we're also talking about our ability as far as taking a history and so on and so forth. So let me just back up here and go down this funnel system. If you've already seen this, especially with this last week, you saw this a lot, but if you're brand new on this webinar, then I'm going to take a moment and go through this, okay? So as DAPC doctors, chiropractic internists, we really wear 2 hats. One hat is the diagnostic hat, that internal disorders, knowing what the name of whatever it is somebody comes in with, or recognizing that it doesn't have a name because it's not actually a disease process. They just don't feel well, right? So that's one hat. And the other hat is the care model hat. This is our care strategy. What are we going to do with what we found? So in both of these, we start off with signs, symptoms, and history. Signs, symptoms, and history. And this is my care hat over here. And this is my name that disease hat here, right? So the one on the left is the one where we come up with the diagnostic. Is it diabetes? Is it, what is it, right? So the first step is the sign, symptoms, and history. I like to have people fill out a lot of questionnaires so I can get a real good basis on that. So things like review of systems are really, really good for finding things, red flags, looking at family history. Sometimes that'll help bring out red flags, and you know, a lot of things they can fill out in their history will kind of point you in that name that disease category. The next thing we're going to do is we're going to do a physical exam. So we start off with signs, symptoms, history. They're doing their questionnaires, and then we sit down and talk with them. And for me, what I do is I go through a systematic way of targeting what things we need to ask them questions on based upon what they filled out, and then we just drill down where we need to drill down. Then we do our physical exam. When we do our physical exam really should be a generalized exam, pretty much that you do on everybody, and then you're going to target it based upon the needs of whatever the patient may have. And I'll give you an example. Let's say somebody comes in and they have, let's say they have cardiovascular. Yeah, let's make it diabetes. Somebody comes in and they have diabetes. Well, in that case, I'm going to really pay a particular attention. Of course, I'm already observing these things about things like central obesity, looking for skin tags, acanthos nigricans. I want to see the fat pad in the tricep compartment. I want to see if it's a man, if they've gynecomastia, if it's a woman. I want to see if she has male characteristics. So there's certain things that I want to make sure. I'm going to do my general exam, but there's a certain things, because it's very specific to diabetic, that I want to really drill down and know what's going on. All right, so now let's back up just a little bit. Back up a little bit. So a person comes in, we don't know they have diabetes. All we know is they get fatigued after lunch and their waist is bigger than their hips. They have central obesity, and they're just a lot more tired than they used to be. Maybe they have frequent thirst. They go to the bathroom a lot, and they've been gaining weight. And in the last 3 months, man, they've just been dropping weight. Okay, so that's my history. So I would take that together, then I do my physical exam. Then when I do my physical exam, I might find things like skin tags, and we're going to go through all this in just a minute. I'm just kind of laying out the kind of the outline of where we're going with this. At the end of the day, we're going to have to go and develop what's called a differential diagnosis. We're going to have to come up with a differential diagnosis, and in the differential diagnosis, we're looking for what categories could be involved. We're looking for what organ systems could be involved. We're looking what systems could be involved. Right. So is it somebody comes in and they're fatigued and they're thirsty and they're going to the bathroom a lot? So there's a couple things we might think in this categories. We actually might put something like, metabolic category. We might put in there endocrine, some kind of endocrine imbalance. These are just broad categories for our differential, So they're fatigued. So we would definitely want to make sure we keep something like maybe infection in there, because infection can do that. We may want to keep even neurological, brain-based stuff. So anyway, so we get these categories. And then once we do the signs, symptoms, physical exam, and we come up with these categories, the next step is, how do we test each of these categories? What labs need to be run to rule in and rule out things, right? So for metabolic, you can run the basic CMP, the lipid panel and these kind of things, and infection, the CBC with differentials. Endocrine, you may run the insulin, you may look at the testosterone. If it's a man, you might look at insulin and let's say estradiol and progesterone and testosterone for a woman. These kind of things. So you're going to order your labs, and once you order your labs, then the labs are going to tell you, yeah, wow, this looks like diabetes. That's what's causing this. And you might have secondary diagnosis. You might have diabetes with a functional hypothyroid or whatever the case may be. But in this hat right here, the whole premise is to walk down the systematically so we can arrive at an accurate diagnosis. Now, this hat over here is really different, but we're going to use the same mechanisms. We're going to find signs, symptoms, and history. We're going to do a physical exam. Now, we're not looking for the name of the disease, but I want to know what systems are involved. If you've been on my teachings before, you've heard the term bail them out, BAIL. So, blood sugar, anemia, infections, inflammation, liver, microbiome. So we're looking for systems. What kind of systems or organs And I'm talking about a care model. I'm not looking for the named disease, but what's not working right? What could be a driver of what is going on? Even if they have a named disease like diabetes, it's not enough just to know they have diabetes. For us, because we're better than just the regular kind of doc in the box that has somebody diabetic and just gives them metformin or Jardiance or gives them Ozempic or whatever. See, we're better than that. So what we're going to do is we're going to say, okay, we named the disease. It is diabetes. Now the next step for me is in the care model hat, I got to find out what's driving it. So we know as a primary driver of diabetes is insulin resistance. So insulin resistance can be caused by simply eating too many carbs, but it can also be caused by infection. It can be caused by inflammation. It can be caused by a poor microbiome. It can be caused by plastics in the environment. There's a lot of things that it can actually drive insulin resistance. And so when we go through the systems and organs, that's what we're looking at, right? So that our signs, symptoms, and history and physical exam is going to lead us not only to the name of the disease, but it's also going to lead us to what do we need to look at? Hey, I pushed on the belly, and man, that liver is really painful. Okay, they might not have a liver pathology, but guess what? It's inflamed, and from a functional standpoint, I better figure out why. So I'm going to run some blood and figure that out. Maybe they tell me, you know, I've had bouts of constipation and diarrhea for the last 3 years, and ever since then, that's when I started feeling bad. Well, I might need to run a Cyrex lab to see if they've got some kind of autoimmune going on in the GI tract. That's array number 14, or I might want to do a stool sample so we can see maybe is there a parasite in there, or is there some kind of bug in there, some kind of bacteria? Do they have irritable bowel disease? You know, so this is how you do this. Now, for the DAPC work, for the chiropractic internist work, you know, we always are going to start. And I remember Dr. Cessna back in the late 80s when my mom and dad, you know, made it afforded possible. When I say afforded possible, they paid my way to go see, you know, sit through Cessna seminars. And Cessna always used to talk about when somebody comes in, we do the history, physical exam, and do blood and urinalysis. This is the basis. This is like the hub of the wagon wheel. We're always going to do that, but based on the case, we actually might do a GI stool. We might get a specialty blood test telling us about allergies. We might get another test to tell us about the endocrine system, the hormone system, whatever the case may be. So I just wanted to lay that out. These are the two hats. Now, let's step forward to what I was talking about. In medicine today, let's just read this, what it says. So several recent studies have described a deterioration in the physical exam skills among modern physicians. Reasons hypothesized for this change are improvements in technology. You know, it's easy. You see somebody, oh, just get a CT. Oh, go get an MRI. Go get this test, go get that test. So the reasons were improvements in technology and time constraints. So this was a real thing. You know, people are under, you know, insurance, and when they're doing insurance, they might have a 15-minute slot. And I don't know about you, but I'm just getting warmed up in 15 minutes when somebody first gets in. So I have to think through this funnel, and I got to think through this model, and I got to think through both of those funnels at the same time. And it takes me more to do that. It takes anybody more to do that. So that's the reason why when you have time constraints like 15-minute appointments, it's going to breed sloppy work. It just is. Let's face it. If you're seeing somebody and it takes you 5 minutes to see them, and you're doing this chiropractic intern's work, and you're doing a full workup on them, and you figured out everything you need to figure out in 5 minutes, I'm going to suggest that either you are a remarkable genius at this, or you know you've got your chat GPT where it's just honed in for you, or you're like me, you have to work through the process that takes longer. Further on in the study, it said, quote, poor physical exam skills are a noteworthy threat to the patient's safety, as they can lead to incorrect as well as misdiagnosis, causing delays in timely implementation of life-saving treatments. So yeah, doing a poor physical exam is going to lead to poor outcomes. The perfection of physical exam skill requires continued efforts and practice to increase its diagnostic yield. So I would say that I've been doing physical exams for, you know, since I've been training in the DAPC and doing the DAPC work. I always did some level of physical exam, but I of course do a lot more now. But if you look at my exam today and look at it in the past, you should see your physical exam getting better and better and better, more efficient, you know, yielding more yield. And so one thing I like to say is that if there's a particular aspect of the physical exam that you feel weak on, like maybe it's the ophthalmoscope looking in people's eyes, well, the next 2 weeks you should look in everybody's eyes, right? If you feel weak on hearing heart sounds, lub dub, S1 2 1 2 3 4 1 2. If you're not hearing that, then you just practice by listening. So this is the schematic that I just talked about. This is the same funnel, but just put in a different way. So here's patient presents. We're going to have them do intake forms, and we're going to observe them prior to the meeting, and we're also going to observe them during the meeting. They have lateral third of the eyebrows. What does their hair look like? What's their appearance look like? How do they walk? How do they hold themselves? How do they talk? All those kind of things. So we're going to link these things to potential metabolic issues prior to the physical exam. This is what we're picking up in the history. And then we're going to move over to the physical exam, which is going to be generalized, but also targeted based upon what you find in the history and the other parts of the physical exam. And then we're going to order labs or test, imaging, whatever we order. And then we're going to have the patient come in and do our report of findings and set out a strategy. And we're going to say, okay, Mrs. Jones, in 6 weeks or 12 weeks, whenever you do it, we're going to do a re-examination. We're going to re-blood this. We're going to do that. I'm going to, go back and look at your eyes again, or whatever you're going to do. But the ultimate goal is for every patient coming in is to develop a long-term life strategy to maintain continued progress. Not everybody's going to go with that, but that's really where you want to get started here. Okay, so hold on just a second here, and okay, so here's the next thing as part of the workup. For a diabetic workup, we're going to use family history, review systems, and your regular sheets, and we're going to do all that. But I'm also going to have them do metabolic assessment form, because this is this hat over on this side, this funnel over here, where we are developing a care strategy. So we're trying to find the drivers. We use that metabolic assessment form. Now, so you want to be suspicious if anybody shows things on this one. Maybe they have brain fog. They get forgetful between meals. They're agitated, easily nervous. They get shaky, jittery, especially if they're hungry. Eating relieves fatigue. Get lightheaded if meals are missed. Irritable if meals are missed. Now, I know this is more geared towards the functional reactive hypoglycemics. I know it's more geared towards that, but in reality, what we're seeing here is that if you have diabetes, you can have big swings in your sugar and you can crash. And so it's not uncommon, it's not that uncommon to see diabetics have some hypoglycemic symptoms. And then here's some hallmarks. Somebody has fatigue after meals, primarily after the noontime meal, right? That's a big one. Increased thirst, frequent urination. That's kind of more, looks like a diabetic, right? But I'm also going to encourage you to look at this one on your diabetics or your pre-diabetics. Look at the prostate and the testosterone section. This is the prostate section. And so you're going to have these questions, urination difficulty or dribbling, pain inside your legs, feeling incomplete bowel emptying, legs twitch at night. So these can be prostate. Now this one's testosterone, so they can have low T, and because there's an inverse thing that happens. The higher your insulin is, the lower your testosterone is. So that's a good clinical pearl for you. If somebody has low testosterone, you want to look at that insulin, and you want to look at maybe are they pre-diabetic. Okay. And by the way, just so you know, I had somebody that's way down the road of pre-diabetes and actually pretty close to being a diabetic, and their fasting sugar was 96, but everything else was just crazy, way out of a line. So ladies, look at the premenopause and menopause things. A lot of times ladies are protected while they're having periods because the estrogen is very protective against diabetes. You can have diabetes, but it's not as common. Now, but in the menopause years, if you see somebody, really, really lighten these up, then that could be consistent with the insulin resistance as well. Remember, just because it's hormonal imbalance here doesn't mean that's what's causing it. many times when we have hormone imbalance, it's coming from other things, like maybe blood sugar dysregulation. So here's some things you can see in a physical exam. Here's skin tags, under the neck, under the underarm. This is acanthus nigricans, well associated with pre-diabetic and diabetes. Now, you could have a diabetic, of course, and not see this. This is a rule in, not a rule out. So here's in the axilla. Here's one you want to look for right here in the fat pad, especially in women. When you get fat, in the tricep compartment, when you start developing fat in there, that's a good indicator that you are insulin resistant. Because when you become insulin resistant, the muscles are one of the places where you store sugar. And what happens is if you get insulin resistant in the muscles, sugar goes into the muscles and just converts to fat. So you get fat muscles. Of course, central obesity, this is just a big estrogen factory here. Gynecomastia, you start developing the man boobs. These, this happens when you are converting testosterone into estrogen. And of course, high insulin is going to do this. So when you are looking at the liver here, and you have high insulin in the liver, it's going to convert testosterone into estrogen. So it's called aromatization. Aromatization, fancy word for saying that you're converting testosterone to estrogen. And for a lady, it's converting estrogen into testosterone. And that's what happens. High insulin makes a woman do this, especially pre-menstrual. So we have the uterus down here. We've got the ovaries over here. So those ovaries, inside the ovaries, you have something called theca cells. And what happens is cholesterol goes into the theca cells and kicks out estrogen, unless there's a whole bunch of insulin. And if there's a whole bunch of insulin, instead of making estrogen, you start making testosterone. Testosterone makes you grow cysts on your ovaries, but it also gives you male characteristics, and you get the you get that kind of beard thing. All right, so shaped like an apple, that does look like central obesity, very consistent with prediabetes and diabetes. So this right here, shaped like a pear, usually this can be an indication that you don't detox your estrogens well. And so you get kind of the side there. All right. So blood pressure is very interesting. Most usually, blood pressure is going to be either level or slightly elevated, 130 over 85, somewhere in that way. But somebody could be hypoglycemic for so many years that when you're hypoglycemic for so many years, if you remember this mechanism, that when sugar goes down in the brain, then it makes your pituitary send an alarm to the adrenals, and your adrenals kick out cortisol, and cortisol quickly gets sugar to the brain. But when you do this day in and day out, day in and day out, you start getting to where you just can't make enough cortisol. And cortisol is regulating your blood sugar, it's modulating your blood pressure, and it's also modulating your immune system. So what happens is you start waning on your ability to make cortisol, and then it is even harder to keep your blood sugar up because cortisol keeps your blood sugar up when it's just in a normal circulation, right? I'm not talking about this is a cortisol surge, and it keeps your blood pressure up. But when they have chronic low blood sugar, they're going to wear down their cortisol, and then when they wear down their cortisol, then their blood pressure will dip 110 over 70. It'll dip below that. They'll be running around with blood pressure at 90 over 60, and they'll tell you, oh, that's normal for me. Well, that might be average for you, but it's not normal, because 90 over 60 is not enough pressure to really push the oxygen into the base of the brain to perfuse the blood in there properly. So it's really not good blood pressure. So you might transition when you're 35 to 40 years old, especially as a female, and you start going more towards pre-diabetic, but you still might be waning there. So you might be pre-diabetic and still have low blood sugar or blood pressure. So those are, I just wanted to bring that point out. And pulse pressure is a really good examination for insulin resistant folks. The reason why it is because, so here is the left atrium and the left ventricle. So when the left ventricle fills up with blood, then, and at the same time, the muscle contracts, then it pushes the blood out like crazy through that aorta, that aortic valve, right? Well, then the blood comes whooshing down the aorta, and just as an example, comes down here, abdominal aorta, some goes this way, some goes that way, some hits here, and it bounces back as a pulse wave. That's a pulse wave. So it's almost like if you're sitting at the beach and the wave comes at you. Well, as that wave comes back at you, now the heart has got to push that blood, it's got to push enough blood with enough pressure to get it past that. So bottom line is, we look at something called a pulse pressure, and it's the difference between the top number and the bottom number. If our pulse wave is coming back a lot harder because we have a stiff artery, and by the way, insulin resistance is a very common reason for the aorta to get stiff. The stiffer that aorta, the faster that pulse wave comes back. The faster that pulse wave comes back, the harder the pressure has to go to overcome that. So now instead of 120 over 80, now we're 140 over 80. Instead of a 40 pulse pressure, now we have 60. So, so on all of your new patients that are diabetic that you're working up, see what that pulse pressure is. It's a great barometer, because after they've been under care for 4 weeks, 6 weeks, 8 weeks, if it was high, if they had a pulse pressure of, let's say, 60, like this one right here, after 4 weeks of care, 6 weeks of care, I want to see that pulse pressure coming down. That's going to be an indicator that we're getting stress off the system. Insulin resistance is getting better. It's not the only indicator, but it's a nice, easy, cheap, accessible way to do it. All right, so we can also check dynamometer. So this is the normal data. If you don't have this, by the way, I'll let you have these slides. All you got to do is contact me, and I will be glad to give you these slides so you can take them. And but anyway, this is normative data for grip strength. So if you have a male that is 45 to 49, they should pull in the right side 109.9 and 100.8 on the left. If they're lower than that, it's a good indicator that they have protein loss in their muscles. Why is that important? Well, let's go here real quick here, okay? So diabetes is a storage condition, right? It's a storage condition. So here's the liver, here's the muscles, and here's fat cells. Now, I'm not going to go through the whole mechanism, but when people eat food, the carbs, and I'll just make it this asterisk, the carbs have to get into these cells. And these insulin receptors, when they begin to tear down because of inflammation, eating too many carbs, too much insulin, all this stuff, you can break down those insulin receptors, and it's like the key doesn't fit in the hole anymore, so you can't get the sugar in as well. So what happens is your body wants to keep your blood at 4 to 5 grams, about a teaspoon of blood. It doesn't want it higher. In fact, if you go all the way up to 8 grams, you can go into a coma. Not everybody would, but some people would. So if you're 4 to 5 grams and your liver is going to fight like crazy to keep it there. Well, when you can't get the sugar efficiently into the liver cells, you just send it into the liver as fat, and then you develop a fatty liver. And now you can't store that sugar in the liver as well. Now you're trying to store the sugar in the liver and the muscles, and the same thing happens there. And then you start just piling away fat in this muscle, and that can cause protein loss in the muscles, which can be seen in the dynamometer. And then you get insulin resistant in the muscles, and then it goes to the fat. And then that's when you start getting bigger, right? That's when you start getting bigger because your fat cells are getting bigger. Now watch this principle. This is very interesting. Genetically, some people will take baby fat cells and just make more big, fill up like baby fat cells will just get filled up, and they'll look like this, and then they'll make another baby fat cell, and they'll make another one, it'll fill up, make another one, it'll fill up. But some people genetically only have so many baby fat cells. They can't make that many. That's the ones, they don't get that heavy, but they get diabetic quicker. In fact, it's almost a paradox. Sometimes you can see this dude that's 450 pounds, 500 pounds, he's not diabetic. And then you see somebody that's 20 pounds, 30 pounds overweight, they're diabetic. Why is that? The reason why that is because the one was 20 to 30% or 20 to 30 pounds overweight, became diabetic. They ran a storage for the sugar. And when they ran a storage for the sugar, what happened is there's no more storage places. So now that sugar went from 45 grams to 6 grams, and we call that diabetes. So if you're getting fatter and fatter, well, you have some protection with diabetes. I mean, there's other problems. For every pound of fat, I think you have to build like 6 miles of capillaries, which isn't that great for you. But anyway, here's what happens. It's a storage disease. I wanted to make that point because when you're measuring the dynamometer, it's a nice little tool, because if you don't see anything, just move on. But let's say a female comes in, she's 50 to 59, and she pulled, instead of 57.3, she pulled 40, and instead of 47, she pulled 35. Well, guess what you're going to do in 8 weeks or 12 weeks? You're going to do her exam and have her do it again and see if she made progress. Right? Ankle brachial index, not a bad idea to do. Check the circulation in the legs compared to the arms. Not a bad idea to do, just simply because you might have poor circulation as a diabetic. Body fat analysis. We've used this machine before, but now we just use a basic Tanita scale. You can get a Tanita scale in your office. People stand on it and they give you a body fat percentage. It's not a perfect, but it's pretty good. If somebody's 25 and it says it's 26 or 24, that's fine. It gives you some kind of basis. Then you come back in 8 weeks, 12 weeks, re-examine, see if you're making progress. And then, of course, these are some of the blood work. All right, so here's what I want to do. I'm at the 30-minute mark, and that's what I wanted to do. And now I want to go through my case history. I had it a little out of order for whatever reason. Now, I have to admit on this case that this was a few years back, and I was seeing patients, and I was in the midst of a busy afternoon, and this patient came in, and they had chief complaint of right arm pain. That's why they were coming in. Now, I do upper cervical as my technique, and so the patient entered with the chief complaint of moderate to severe right shoulder pain radiating down his arms, hands, and fingers, and patient relates a burning sensation inside his arm, right side, and numbness in small digit, ring, and middle finger. Well, my wife was seeing this patient as a new patient, and after she examined him, she felt like what he needed was upper cervical care. Now, you've heard the old adage, happy wife, happy life, right? So it's a busy day for me, and I really don't have time for a new patient, but I did have time. If we could shoot an x-ray, I'd get him adjusted real quick, talk to him a minute, and then have him come back the next day, and we'd actually I did enough examination to be safe with my adjusting, just like I normally would, but I was going to come back the next day, and then we would finish up, kind of shore it up. So that's kind of where it happened, right? So the patient reported that 2 months prior, a very similar pain developed on the other side. He went to his medical doctor. The medical doctor told him to do some stretching, put some hot towels on it. It actually got better. And then this time when it happened, he's like, I got to figure out what's going on. Then he winds up in our clinic. He sees my wife, who's a doctor of chiropractic, and she refers him to me. I'm a busy afternoon. I looked at him. And so when I first looked at him, well, let's just read the rest of the history and I'll talk about that. So additional history. He was rear-ended while driving a dump truck 6 years prior, moving at a speed of 60 miles per hour. Oncoming vehicle was doing 95 miles per hour. It's like being at a dead stop and getting hit at 35 miles an hour, doing 60. He had neck issues following, along with right arm pain. Patient reports occasional dizziness, probably cervicogenic, vertigo, and a sensation on the right side of his body. So something's going on in that spinal cord, medulla, something, right? So his blood pressure began elevating 5-6 years ago. I think it's no coincidence because it was after he got rear-ended, because we know that that upper cervical spine, when it is not in proper alignment, can drive hypertension, right? So patients, it could be. So the patient reports using natural supplements for a few years with success. So he started taking, the things that people taking, things to improve nitric oxide, maybe take some citrulline, takes arginine, different things like that, and his blood pressure got better. So 1 year ago, he had to go on medication to lower his blood pressure because all of a sudden, I want you to remember that, all of a sudden his blood pressure rose. Additional history. So the patient reported that 6 months ago, he developed a rash on his back. He went to his primary care doctor. After examination with his primary, he was referred to a dermatologist. He has had 3 office visits with the dermatologist and is scheduled to repeat a visit in March. This was in February. So I want you to catch that. So 2 months ago, he saw his medical doctor, and 6 months ago, he saw his medical doctor. So he's had 2 visits with his primary care doctor, and he's had 3 visits with the dermatologist. So he's had 5 encounters in the traditional medical world. All right, so just keep that in mind. And so I had this out of place. Now, let's go here. This is him. So let's do some observation. What do we see? This is that, remember that telangiectasia? So in a man, telangiectasia can be associated with cardiovascular disease. Now, just like any physical exam finding, we don't look at that and say, you have, cardiovascular disease. When we see something as a finding in the physical exam, it is an invitation for us to say, oh, I wonder why that's there. Does it fit the pattern of cardiovascular disease? And then I go back, did he have shortness of breath? Did he have other signs of cardiovascular disease? It does have high blood pressure, medicated, right? So then I'm going to do a physical exam. I'll look at things like diagonal crease in his ears. Does he have hair in his legs? Does he have a fungal toe? What does the ankle brachial index look like? So we're going to be looking for things to give us a clue about that, seeing that. So I don't see a lot on his hand. Okay, so we got a little fungus on the toe, but the other toes are fairly clean. What does that tell us? Kind of a rule of thumb. If you see a big toe like that, that's fungal, but the rest look okay, most likely scenario is it's from a drop in circulation, which speaks of cardiovascular disease, right? This is the back. This is the red inflamed back that he went to the dermatologist for. This is his belly. This is a cherry angioma. And sometimes, and this is where the liver lives, so sometimes if you see that cherry angioma right where that liver lives, it can speak of a hormonal imbalance. Here again, you don't look at that and say, you have a hormonal imbalance, but you would say, look, that could fit a pattern of hormonal imbalance. Let's see if we see anything else. That's it right there. And of course, he has the gynecomastia. So there is a hormone imbalance. He's converting some testosterone into estrogen, right? All right, that's the gynecomastia. He's got a bit of central obesity as well, right? Not sure what that picture's for. Oh, he's got a geographic tongue. So a geographic tongue is simply it's an inflammatory process. So if somebody has a geographic tongue, then it's an inflammatory process. The two places are the place that you're most usually going to see associated is in the GI tract immune system. So something is inflaming that in the GI tract. Now, for sure, geographic tongue can be associated with things like psoriasis and even an autoimmune where your white blood cells are attacking the papillae in the tongue. But if it is autoimmune, and psoriasis is autoimmune, but either one of those autoimmune, guess what you're going to see? You're going to see gut GI problems, right? You're going to see gut immune system. So when I see a geographical tongue, what I think about it's inflammatory. Let's see if it fits a pattern of GI findings, right? So here's some of his other findings here. Right deviation tongue, we don't care too much about that. Horizontal saccades, gynecomastia, fungal toe, and discolored on the inside of the ankle. Didn't see that. That's also cardiovascular disease. So let's look at our funnel, right? Let's look at our diagnostic funnel, if you will. So signs, symptoms, and history. he didn't really give us much other than we know that he has high blood pressure, so that's something. We did his physical exam findings, and we found discoloration inside the ankle. We found telangiectasia. We found fungal toe. These things all speak of drops in circulation, right? We found gynecomastia, which speaks of, you know, low T, maybe high E, high estrogen, so some hormonal imbalance. We found central obesity, which is consistent with insulin resistance. So these are the systems that we're going to be looking for. So I want to run some labs to know about cardiovascular disease, insulin resistance, what's going on with testosterone. We're going to see all that. And at the end of the day, we're going to see if there's a name here, because there might not be a name. He might just be not feeling well, right? Now, notwithstanding he has the thing going on in his neck, we're still appreciating that. But this is what it looked like. All these pictures that I just showed you right there, I literally did that in 5 minutes. So he sat in my chair, my upper cervical chair, to get evaluated. And I looked at him and I could see some things were off. And I said, let me look at you real quick. You have a couple minutes? I'm already backed up. I'm feeling the pressure. You know, people are in there and I'm trying to go, but I said, you know what? I got to look at something. So I looked at a few things. I saw these things. And what I told him, I said, look, here, and that's my exam findings right there. I said, look, I don't have time to do a full workup on this today, but Mr. Jones, I would like to very minimally do a non-fasting, just a little bit of blood work just to see what's going on. And he's like, okay. Now, keep in mind, he came in completely for a musculoskeletal problem. He didn't, like, he came to a chiropractor. He had no idea where chiropractic interns. He went to go see my wife, and he was just, you know, he didn't get us in the yellow pages, but he just said, okay. Matter of fact, we do DOT physicals, and so he knew us from the DOT physicals. So he just came in. My wife sent him in there. So he's fresh. I spend 5 minutes. I'm like, look, you've got gynecomastia, right? You got signs of cardiovascular disease. We know you have the high blood pressure and the central obesity. There's maybe some sugar balance. We need to take some very basic labs. I'm going to adjust you today. I'm going to have you come tomorrow, and then we'll go over those labs. And this is what we found. His fasting labs were 205. Well, we know he's diabetic. That's not supposed to be like that. You know, as a non-fasting, it shouldn't be like that, right? Shouldn't be that high. We also found that his EGFR, which is kidney, he has stage 3 kidney disease. I'm not too concerned about that, although that could be connected to cardiovascular disease. Because what's going on here? Look at this. This is an important key. Here's the kidney. The heart sends blood to the kidneys, and it goes through this filtration system, and the junk goes into the urine. Clean blood goes that way. But really, what the kidneys are is a whole bunch of small arteries. So when your kidneys start coming down, you always have to suspect cardiovascular disease. So when I see that, it fits the pattern, right? Telangiectasia, discoloration of the ankle, fungal toe, and even the diabetes. All of these things are giving me a picture. Hey, this dude's probably has some cardiovascular disease. Yeah, he's masking the blood pressure, which is a good thing. It's not good to have a high blood pressure with a drug, but he hasn't resolved the problem. So that's what I tell people. You know, you may solve a problem with high blood pressure medication, but you haven't really solved the problem, which is what the heck is going on. That's where you need the care model funnel. So don't really see much there else there, but that's a lot. So his LD's elevated, and when you see LD elevated like that, just remember that LD does this. Sugar goes into the cell, gets converted into pyruvate, and then pyruvate either goes into the Krebs cycle or it goes to lactate. When it goes that lactate pathway, then you use that LDH enzyme to convert pyruvate to lactate. When you're doing that at 256, it's not necessarily a disease process, although diabetes and cardiovascular disease is a disease process. But it's not a disease process like a cancer or, you know, something like that. This just means he has a tremendous amount of inflammation going on, a lot of inflammation. He's on fire. No wonder his arm's hurting as bad as it's hurting. I know his upper cervical, his cervical spine's off, but it's not just that. He's got a lot of metabolic issues. Now his TSH is at, if you see that right there, is at 3.17. We like to see the TSH at 1.8 to 3.0. When it goes over 3.0, but is under 4.5, then it is a functional primary, I shouldn't say it that way. I'm not going to say it that way. It is a functional hypothyroid. It's a functional hypothyroid. If it's over 4.5, it's diagnosable in the Diagnostic Hat as a primary hypothyroid. This is not. But my assumption is he's got so much inflammation going on that his thyroid is just wigging out. His white blood cells are sitting up there at 10, right? Anytime you see your white blood cells above 8, you have to be suspicious of an infection. Now, red blood cells high, hematocrit is high. This is probably happening maybe because he's dehydrated, because he has diabetes. He's just peeing things out like crazy. It could also be his body's fighting for oxygen. Look at this. His eosinophils are high. We want to see the eosinophils be less than 3%. And what we see here is that it's at 12, so it's 4 times what it should be. Let me give you a quick lesson on this, okay? So when we look at this, lining, let's do it this way. Okay, you breathe in, here's my lungs, right? So I'm breathing in. Lining the respiratory canal and also lining the GI tract, you are actually full of mast cells, all kinds of mast cells, all kinds of mast cells. These mast cells are full of histamine, okay? So when something triggers the mast cells to break open, not only do they release histamine, but they also activate IL-5. IL-5 goes to the bone marrow and activates you to kick out eosinophils. So that's the allergy connection. So when somebody has an activation of mast cells, you're going to see increased levels of IL-5. IL-5 increase is going to increase your eosinophils. This is a histamine reaction. That's probably what's going on in his back. I think also when we look at this, I'm going to cheat just a little bit. You have to go with me on this. Neutrophils are 58.5. Lymphocytes are 21. Now remember, we like to see 60-30 neutrophil lymphocyte. But in this case, the eosinophils are crowding out 10 percentage points almost. So if you look at this relative, I know it's hard to do it this way, but I think he's fighting not only that, but I think he's got a bacterial infection going on as well somewhere. Because even though 58.85 is not over 60, you got to measure it relative neutrophil lymphocyte. If you look at it relative, the neutrophils are higher than they should be in that equation. So the lymphocytes should generally be half of your neutrophils, and the neutrophils are higher than that. So I suspect maybe a bacteria that's going on. So, and it could be, and I don't know that. We would have to work that up further. But when we look at this right here, 10.3, it just makes me suspicious of that. So I was like, whoa, look at that. Let's run some more blood. So we did. This time we did a fasting, and look at his blood sugar, 230. We did a homocysteine. It's high. Now that might be from a genetic SNP, but it might just because he has so much inflammation going on. He was on a statin, right? He's on a statin. He didn't disclose that to start with. Remember, he just came in, his back hurt. He wasn't coming in for all of this. So even this, you see that triglyceride to HDL ratio is above 3, which is consistent with insulin resistance, right? Glucose is high. Hemoglobin A1C is 10.1. What does that tell me? All right, so what is hemoglobin A1C? It is the average of your blood sugar over the last 8 weeks or so. So here's my hemoglobin, and sitting on my hemoglobin. We have these oxygen receptors, and not only that, but sometimes we get a bunch of sugar floating around the blood, and that sugar can attach itself to that hemoglobin. How much it attaches itself to it gives us a watermark of how much sugar's been in there on average. Now, I want to bring out, he's been to his primary 2 times. He's been to a dermatologist 3 times. He's had a total of 5 traditional healthcare visits. I don't blame the dermatologist much because that's not really his field, but he did have 2 appointments. And how long has this diabetes been going on? You know what I think? I think it started 1 year ago when all of a sudden the natural stuff didn't work for the blood pressure. I think he broke through at that moment. His sugar started going up, and that's when he could no longer do his blood pressure with taking, you know, the natural stuff that people take. All right, so we also did T3 uptake. T3 uptake, when it goes above 34, we start thinking about insulin resistance. 39 is way up there. His ferritin's pretty high. I like to see that under 100, you know, 40 to 100. His C-peptide is elevated at 4.24. I don't see his insulin. I'm not sure why I don't have the insulin on here. I should have had the insulin. I apologize. I don't see it though. Okay, so here's what we do. What do we do with this, right? So all right, I'm trying to find an easy place to go here because we're coming down to the end of the program here. All right, so let's put a few things together. All right, C-peptide. All right, so in your beta cells, in your, you know, those islets of Langerhans, those cells in the pancreas, that's where you make insulin. But you also make C-peptide there and GABA, right? So C-peptide, or proinsulin, is about 1/10 the strength of insulin. But when you make insulin, it has a half-life of about 2 to 3 minutes. So it's there and it's gone. When you make C-peptide, it lasts a long time. And so therefore we can measure C-peptide and we can get a more accurate picture of how hard the pancreas is working. We want the C-peptide to be 1.5 to 2.5. I said that wrong. 1.0 to 2.5. That's a perfect C-peptide. Now, if somebody's diabetic and they don't know they're diabetic, or even if they do know they're diabetic, then it's going to sound funny, but I want that C-peptide to be high. I want it to be greater than 2.5 because that means that you have the ability. So we want to be greater than 2.5. That means that pancreas is working like crazy. Now, it's not good to keep it that way. We got to reverse the diabetes, but at the same time, that tells me that, okay, it's able to work. Now, what's more scary is somebody has a hemoglobin A1C of 10.1 and fasting blood sugar at 230. Would be more scary if a C-peptide was down to 1.0, because what that would tell me is his pancreas doesn't have the ability to make insulin. And if you don't have the ability to make insulin, what that means is either you have very weak kidneys or you've been diabetic for such a long period of time that your pancreas has just given up, and you are threatened to be an insulin-dependent diabetic. Now, we can still work with these folks. It just takes a lot longer. So when I actually see the C-peptide like we did on him at 4.24, I actually like that. I know that it's burning hot, but we've got a chance to reverse it. So this was our initial plan. Before I do the initial plan, I want to see here. I'm going to try. I am going to do my best to close it up in 5 minutes, but we might go an extra minute or two. So what did we find? Okay, so number one, in the history and so forth, all we know is blood pressure, and he knows he has the back pain, right? So the next thing is we did a physical exam, and the physical exam really pointed to cardiovascular disease, testosterone problems, to estrogen, and insulin resistance. These are the things. Now, you don't make conclusions on your physical exam. You just look at it and it's suggestive. We did the blood work, and what did we find? We found that he's a diabetic and he didn't know it. And I believe it does support that he has cardiovascular disease. The kidney disease is there. The diabetes is there. The hemoglobin A1C has been, so sugar's been up for a while. I do think he's looking at cardiovascular disease. He needs a more extensive cardiovascular workup. That's what I would do. All right, we found that. But secondarily, we found low functioning kidneys, stage 3 kidney disease. We found a low functioning thyroid, right? We found high eosinophils, so probably associated with allergy. That probably has to do with the back thing, and a potential, and I'm only saying potential, we're not doing anything with it right now because we don't know what it is, right? And then we had the bacteria, the elevated T3 uptake and C-peptide. We expect that goes along with the diabetes, but it's good to know that so you can measure that. So these are things that we know, all right? So what else do we know? Well, we know that with diabetes and cardiovascular disease, there's really 2 steps you want to take. First thing you want to do is you got to support it. And second thing you got to do is you got to find the drivers. You got to support whatever it is and find the drivers. For diabetic, how do we support diabetic? Well, one of the things we're going to have to do is just a blanket. You got to cut the carbs. If you're diabetic, you can't just keep on eating carbs because diabetes is a carb storing problem. You're not storing carbs well. You're not storing the glucose well, and it's a storage disorder. So feeding yourself more glucose is not good. So we know that as general. But we also know that for diabetics, when it comes to drivers, we want to look, is there inflammation going on? Well, look at those eosinophils. Look at the white blood cell count. Something's causing the thyroid to be low. I think that's inflammation. We've got to find some of this inflammation. And some of that inflammation at this point could simply be insulin being too high, blood sugar being too high, that, the age. If you remember, we have advanced glycation end products. That's where sugar is floating around. Let me do this real quick here, where sugar is actually floating around in your blood and glomming onto proteins. So you've got your blood vessel coming here, and then you've got your protein sitting here like this, and then you get this sugar molecule that just grabs onto it. Now it's an advanced glycation end product, and now your immune system is going to look at it and say, I don't like you. It's going to react to it. So if you have a lot of glucose, you're going to have a lot of inflammation. So back to the cardiovascular. The first thing to do is identify. So before I really do much with cardiovascular, I'm going to do a more extensive, I'll do a cardio IQ workup for that, right? So what does it look like? I will put him on a 12-week program to start with. For sure, we'll start with Blood Sugar Bootcamp. It'd be a good idea to find out what foods he's reacting to, right? And that would be a good place to start. I would add some berberine. Berberine is something that's really good for your insulin receptors. It helps heal the insulin receptors, helps with blood sugar. So his blood sugar is way out, so let's give him some. There's something called Gymnema sylvestri. Gymnema sylvestri is an herb that helps rehabilitate the pancreas. So it'd be fine to take that as well. So I'm going to try to the first 2 to 4 weeks. I'm going to do this hardcore, probably put him on a ketogenic diet, and I'm going to watch his progress, see how far he goes, and then I might need to institute new things. So here's what we did, and then we're going to be finished in a couple of minutes. Please hang on with me. Initial 2 weeks, Blood Sugar Bootcamp. We did Designs for Health 14-day paleo detox consisting of protein powder, enzymes, HCl, and L-glutamine. We had him do 2 shakes a day along with a ketogenic diet. Beginning on the 3rd week, he continued with the shake with 1 shake a day, but all else was the same. Then we began counseling him on what intermittent fasting looks like, trying to go. We already had him start with doing 12 hours between breakfast, last bite of food and breakfast, but we wanted to inch that out to 14 to 16 hours, see how we did. We had him do berberine, HCl 3 in the morning, and we had him do Gymnema sylvestri. Berberine comes from Biotics, and Gymnema sylvestri, I believe it comes from Numedica. We did our upper cervical chiropractic care. future recommendations is I want him to do his fasting blood sugar and give us a report. Let us know. Don't wait. I'm going to see him in 2 weeks. I'm going to see him sooner than that, adjusting. But I want him to send it to my nurse, my deputized nurse, because I want to know what's going on with that blood sugar fast and make sure it's coming down. In 4 weeks, I'm going to repeat the homocysteine and see what we need to do with that. I'm going to repeat the C-peptide and the CBC. I want to see what happens to that white blood cell count. Did it come down once we kind of got everything settled down? What happened to the eosinophils? 12 weeks, we're going to repeat the full blood work. And I would say we need to also additionally do a full cardio IQ, and I need to test his testosterone, right? So as soon as it's safe to do, I'm going to have him doing some interval training. And we may look into doing the Dutch test for hormones with the testosterone and the other. So that's kind of what it looks like. So fasting sugar numbers went from 200 to 230s down to 130 within 2 weeks. And it remained that way, that range for the next 4 weeks, for 6 weeks. The patient reports overall feeling better. His original pain pattern, numbness, has improved 80–90%. Patient additionally reports improved in skin condition. Now, this is the last one. This is the funny thing. I got 2 funny stories to tell you. Stay with me for just a minute here. The first one goes like this. I found this, and I said, Mr. Jones, you have diabetes. And he said, I didn't know that. I said, wow. I said, so he said, oh, do I need to go to my primary care doctor? And I was joking. I don't know why I said this like this. I said, no, I was the one that found this. I get to play with it. And so anyway, he stayed with us. Other things went well for a while. Here's the funny thing. He canceled his March dermatology appointment because by the time that came around, his back had completely cleared up. Now, he'd had 3 dermatologist appointments before then, 2 office visits with his primary. Nobody caught this diabetes. And who knows how long he'd walked around, maybe until it became a crisis, before somebody found this. Now, he was still very medically minded, right? He was still in that groove. He was doing what we said because we found something, and he was a compliant person. 6 weeks into care, unfortunately, this is just a real story. 6 weeks into care, he had a cold. He started having a cold. He went, instead of coming to see us, which he should have, he went to his primary care. We should have been his primary care. He should have seen us that way, but he's more medically minded. He goes to primary care. He has a cold. The primary care gives him a shot of steroid. What does steroid do? Steroid raises your blood sugar. So his blood sugar is all down. It was all getting down even to the 120s. He took the steroid. It bounced back up to 200. And he said, I don't know what's going on. He went to the medical doctor. Bam, medical doctor put him on metformin, Jardiance, and I never saw him again. So that was an unfortunate case for him because we could have really saved his life and just given him years to his life. But unfortunately, he missed the boat. He just missed the boat. But anyway, that is the diabetic workup. I certainly hope you guys have had a great time with this. I'm going to look to see if we've had any questions. And I do not see any questions. So if you want to watch this again, we're going to put the video up. I see Dr. Pones out there. That's good. I see Dr. Moore's out there. It's good to see you. I'm so glad you're out there. There's a whole bunch of other people out here. I don't see it, and I don't want to skip anybody. I see Dr. Anderson's out there. That's good. All right. Well, it's good to have you guys out there. God bless, and I hope you got a lot out of this. We're going to do this again next Tuesday. I'm sorry, next Tuesday. A month from now, the last Tuesday. The DAPSI sign up. If you're not done it, DAPSI sign up. It's March 21st, 22nd. If you haven't done blood work for a while and you're not in the current program, come and join us. We've got some new stuff. You're going to get a lot of information. It'll be well worth your time going through that seminar. It's March 21st and 22nd. It's the Friday, Saturday. I might have that date off one day or the other, but it's in there. So join us for that, and also join us for the next webinar. God bless you guys. Thank you so much for joining, and I had a great time doing this. I hope you had a great time listening.